at Texas HHSC. I am quite pleased to be your host for this conference session. We will continue with day 2 of our 2020 Southwest First Episode Psychosis Conference with this amazing breakout session entitled Building a Learning System of Care, Using Data and Outcomes to Advance Early Psychosis Care. I want to thank our wonderful speakers for being here with us today. And of course, many thanks to all of you for joining us. We truly hope that you find today's presentation engaging and helpful with your work. So next slide, please. All right, to start off, I'd like to cover a few housekeeping items. First, we have made every attempt to make today's presentation secure. If we need to end the presentation unexpectedly, we will follow up using your registration information. All attendees are in listen-only mode and cannot share video. If you have a question for the presenters, we ask that you submit it through the Q&A pod. We have staff monitoring the pod, and we will do our best to respond to as many questions as time allows. If you have a comment or want to share a resource with all the attendees, please use the chat box. The event is captioned. To view captions, click the arrow beside the CC box at the bottom of your screen and choose Show Subtitles. To change the size of the subtitles, click the arrow next to the CC box and choose Subtitle Settings, where you'll find the option of making the subtitles smaller or larger. The slide deck is currently available through your Crowd Compass app. Following the conclusion of the conference, we will also post links to a recording of the sessions on our MHTTC website. If you'd like a certificate of attendance or CEU certificate, a certificate reflecting your total hours of attendance at the conference will be emailed to you within the next 2 weeks. You must sign into the session through your conference registration to document your participation. Conference registrants are responsible for checking their licensing or credentialing board to ensure acceptance of the CEUs that have been issued. Lastly, we would love for you to share your comments on social media using the hashtag SWFEP2020. Next slide, please. So our disclaimer, this presentation was prepared for the MHTTC network under a cooperative agreement from the Substance Abuse and Mental Health Services Administration, also known as SAMHSA. The opinions expressed in the presentation are views of our speakers and do not reflect the official position of the Department of Health and Human Services or SAMHSA. Next slide. All right, let's get started. Next slide. So today we have 4 amazing presenters for this breakout session. First, we have Dr. Annette Crisanti. She is the Vice Chair of Research and a professor in the Department of Psychiatry and Behavioral Sciences, University of New Mexico. As a psychiatric epidemiologist and mental health services researcher, her research aims to address behavioral health disparities in rural communities and among vulnerable populations by developing, implementing, and evaluating innovative approaches to behavioral health services. We also have Bess Friedman, who has a Master in Science in Early Intervention in Psychosis from the Institute of Psychiatry, Psychology and Neuroscience at King's College London, and returned to the US to assist in the development and evaluation of coordinated specialty care programs for First Episode Psychosis. Through the University of Pennsylvania's Department of Psychiatry, she led the evaluation of 9 coordinated specialty care programs throughout Pennsylvania. She is currently a program specialist at the University of New Mexico's Department of Psychiatry and Behavioral Sciences. We also have Dr. Molly Lopez, who is an experienced in program evaluation, project management, grant writing, and research dissemination. Her research interests include mental health service systems, implementation of evidence-based mental health interventions, and strategies for enhancing workforce competency. Dr. Lopez is the director of the Steve Hicks School of Social Work's Texas Institute for Excellence in Mental Health. And last but not least, we have Dr. Debbie Cohen, who is mental health services researcher and policy expert. She is an assistant professor in the Department of Psychiatry at the Dell Medical School and a research assistant professor in the Steve Hicks School of Social Work. Dr. Cohen partners with providers and state systems to examine system, program, and practice barriers to effective care delivery in order to improve access, engagement, and outcomes for youth with emerging serious mental illnesses. Dr. Cohen serves as the evaluator on the SAMHSA Clinical High Risk for Psychosis grant within Austin, Texas, and is a co-investigator on the 23-site study of Texas First Episode Psychosis sites. Thank you to all of our presenters for being with us today. Bess and Annette, I will pass it off to you. Next slide.
Good morning. Well, I was going to say good morning, everybody, but I just realized that people are calling in or joining in from all different time zones. So I'll just say hello, everyone. Really happy to be a part of this session. We have a lot to get through, so I'm just going to jump right in it. Today, Bess and I are going to be talking about evaluating coordinated specialty care programs, and here are our objectives for the next 20 minutes or so. We're really just going to provide a brief overview of what program evaluation is and why it's important to evaluate coordinated specialty care programs. We thought it'd be helpful if we reviewed some of the barriers to implementing program evaluation, especially from some of the lessons that we've learned along the way, which data should be collected and how the data should be collected, just to kind of give you some helpful tips that you might be able to take and implement when you go back to evaluate your coordinated specialty care programs. So next slide, please. We're going to start with a poll. We thought it might be helpful just to get an idea of how experienced or what sort of experiences the audience has had with respect to program evaluation. So if you can all just sort of let us know in what capacity have you been involved in program evaluation, and select all that apply, because we know that a lot of our roles overlap and we wear a lot of different hats these days. And then I think Molly is running the poll, and so we can hopefully see the results when they come in.
They're still coming, so just a bit more. Okay, I will end the polling.
Okay. So we have about 219 participants joining today, which is really exciting. Thank you all for joining our session. And it looks like we have a real mixed bag. So about 27% have been involved in implemented evaluation processes and systems. About 23% have led or coordinated or directed evaluation efforts. Looks like the largest percent has been involved in helping or collect data. And then another sort of 35% of you have used program evaluation to inform policy program or clinical decisions. And 35% have had no experiences. So hopefully this session today will help you with learning how to do some evaluation of your coordinated specialty care program. Next slide. Okay, so let's begin. What is program evaluation? As you can imagine, there's all sorts of definitions for program evaluation, but Bess and I really like this one from the CDC, which is the systematic collection of information about the activities, characteristics, and outcomes of programs to make judgments about the program, improve program effectiveness, and or inform decisions about future program development. That is a really loaded definition. It's so rich with information. I want to point out a couple of key things. It's the systematic collection. So it's a process that you set up to collect these data rather than just sort of going willy-nilly collecting information. And it should serve a purpose and several purposes. You want to make sure that you're collecting these data for a reason. Or several reasons, right? To help make judgments about the program or improve program effectiveness. Hopefully, maybe it'll help you collect opportunities or find opportunities for future funding. So when you're setting up your program evaluation, you want to kind of remember these bullets along the left-hand side. It should be practical and feasible. You don't want this to be a burden for those people who are involved in helping you collect the data. It should be useful. That's probably one of the most important things. It should be ongoing. I've already talked about it being systematic. It should be collaborative and flexible. We've noticed with respect to our program evaluation that we've had in place, when COVID happened and is ongoing, we really needed to be flexible. And really, some people always talk about, well, what's the difference between evaluation and research? So we kind of like to think about evaluation is really designed to improve, whereas research is designed to kind of prove or disprove a hypothesis, more hypothesis driven. Next slide, please. All right, so why collect data for program evaluation? We kind of divided this into two sort of categories. At the client level, we really want to sort of set up our evaluation to help monitor individual progress, right? And then also to provide some feedback to clinicians who are collecting or helping you collect those data. It should be useful in sort of modifying maybe treatment with respect to medication, looking at engagement, that sort of thing. At the program level, this is sort of a big area, but we kind of highlighted 3 areas in terms of identify areas for improvement, determine if strategies for improvement are successful. So one example that Bess was kind of talking about the other day with me is that she said, you know, sometimes you want to increase psychosis literacy in the community and increase their understanding or awareness of where to refer to coordinated specialty care. And so she might go out and do targeted sort of outreach with schools or with sort of primary care physicians to let them know that there's a coordinated specialty care program in the Department of Psychiatry called the Early Program or the Connect program for those people at risk of early psychosis. And so we should really be able to look at whether or not those outreach efforts increased our number of referrals following those outreach efforts. And then this kind of looks, that ties into the third point, which is to use results for outreach and advocacy. Again, to reach out to communities, increase awareness of coordinated specialty care programs in the community, and then also to increase support for those sorts of programs. Next slide, please. All right, this is my last slide. I'm going to turn it to Bess after this, but I just thought I would end by talking about some of the challenges and barriers that we've experienced, and Bess will go into a little bit more detail about that. But some of the challenges is that when we introduce evaluation, people are like, oh man, you know, we cannot do anything more. We are already at our max. And so we really have to be mindful when asking clinicians, even clients, to give us data, that we have to be mindful of the time that it takes for clinicians to do that, and then modify our sort of surveys or tools accordingly. And we want to be mindful that this is, you know, a burden on clients as well. So we want to coordinate those data collection efforts with when they're coming in for their clinical appointments. We don't want to kind of schedule a different appointment just to collect data. And then, yeah, there's always some sort of cost involved in setting up these systems. And then just some other challenges that we thought about looks at sort of engagement and follow-up completion. And so baseline data is good, but unless we have follow-up data, we really aren't going to be able to look at the outcomes of individuals who are involved in coordinated specialty care programs. And then also most of these data, especially when we're getting the data from the clients, of course, is self-report. So sometimes we have to sort of just be concerned about the reliability of that information. So all of that saying is that why we put a lot of thought into which data to collect and how to collect it. So I'm going to turn over to Bess.
Thank you, Annette, and hello, everybody. So building off of what Annette just kind of went over, those challenges and barriers, we're going to start looking at which data specifically to collect. And there's a bunch of different strategies, but one of the first, and I think the most important in considering which data to collect, is utilizing existing data whenever possible. So as many of you may know or are used to anyway, there's a lot of reporting requirements for clinical programs that already are in place, whether it's for insurance reimbursement or for your agency. And a lot of that can become redundant. So there may be different measures of suicide risk or safety risk. And so trying to minimize that redundancy and utilize existing data wherever possible is really important. The next and equally as important would be getting stakeholder input. So I think yesterday, the speakers from ESA were talking about the importance of having clients and their identified families provide input into what kinds of measures are important to them in looking at the success of these programs and at the success of individual clients and how they define recovery. So getting input from stakeholders also includes the clinicians themselves, agencies and the organizations that are supporting these programs, and then county and state level policymakers. And they may have different kind of areas of interest when it comes to what they want to see as a measure of success. So it may be related to cost or inpatient hospitalizations, or it could be more based on functional recovery and measures of self-determination. But in the end, as evaluators, after getting this input, we want to kind of see where the overlap is and what we can use for multiple purposes to be most efficient, and prioritize those outcomes first, the ones that are overlapping. And then lastly, using both clinician and client self-report scales. So the clinicians and the clients are the experts, especially the clients, and having them complete this instead of a third-party evaluator can again reduce redundancies. And it can also allow for interesting comparisons between the clinician and the client, and where they may agree or differ in terms of the client's progress. Next slide, please. So we're going over this really briefly, so I just want to put a disclaimer that this is, just touching the surface. You could go into very minute detail of each of these different outcomes and how to measure them. But overall, in looking at coordinated specialty care programs, there seem to be some general common domains for selecting outcome measures. So the first would be referral processes and DUP. And this is because one of the main goals of coordinated specialty care programs is to reduce the duration of untreated psychosis and have a rapid referral process. So looking at those variables can be really important. Also, of course, clinical symptoms, level of functioning. And again, I think what I learned from yesterday, like how you define functioning or recovery, and maybe scales for self-determination or things like that could be really interesting. Engagement and service utilization. So how common is it for folks in your program to utilize the array of services that are provided by CSC, or are they just seeing one or two providers, maybe a psychiatrist and a therapist? And then what are the factors or things that keep someone engaged in the program versus their disengagement and being discharged from a program? And then demographic and socioeconomic characteristics, of course, are helpful to kind of describe the population or the folks that you're working with in your catchment area. And then lastly, fidelity to the CSC model. And this becomes especially important when looking at multiple CSC programs and doing an evaluation within a network of programs, which our next speakers are going to speak more to. But it also is important for single program evaluation to kind of be able to know what it is you're providing and use that as a platform from which to explain the outcomes that you see. Next slide, please. So again, there's a lot of different debate over each and every variable and outcome measure, but there are some guides for selecting measures and variables. One option is to look at already required data collection tools, such as the NOMs from SAMHSA, and to kind of match up what you're collecting in terms of socioeconomic economic and demographic variables with the variables that are already there. The other option is to kind of look at different toolkits. So the Phoenix toolkit was put together by a panel of specialists, and for psychosis, they have it for different illnesses and diseases, but for psychosis in particular, they have a clinical research toolkit as well as a clinical practice toolkit. And they recommend, they recommend outcome measures based on validity and burden. The NASHFID use of performance measures guide is really wonderful because it kind of surveyed across the US to see what people were using and what was most commonly used, as well as kind of rating those measures based on their burden and validity. And then lastly, I like the evaluations questions checklist because it just kind of goes over, in general, any program, what are the things that you want to look at? Next slide, please. Okay, so how do you collect the data? One of the things that seems most logical, if you're going to use existing data and utilize, already kind of required reporting measures, to use the existing electronic health record system from your program. This reduces redundancy in data entry. It makes the outcomes accessible for clinical use. Your clinicians are already used to using the platform, and they're already entering the data in there. However, electronic health record systems, as many of you may know, are not always the smoothest and can be kind of clunky. So there are a number of different issues that can come up with this, and I list them there, but we're going to move on. Next slide, please. So one of the solutions that a lot of us evaluators have come up with is to use web-based platforms instead of the electronic health record system. So the benefits to using these are that they are HIPAA compliant and they're user-friendly. They can be designed to be user-friendly so that you're just sending a link in an email to the clinician to complete or to the client to complete. And you can set up automatic reports or automatic alerts for when reassessments are due. However, it is an additional platform for clinicians to learn to use. And it requires, a certain amount of staffing for designing the platform, tracking, and IT assistance or training for clinicians to be able to enter data. Next slide, please. So there's a couple other considerations that we've listed here. And again, this is a really kind of brief, broad overview. There's a ton of different factors that have to be considered when designing an evaluation. But just to list a couple here, contacting your local or institutional IRB and determining, what the purpose of your data collection is and what's required by them, whether you need to get consent from participants, if you're going to use compensation as an incentive for clients to complete surveys. The time frame for collection and entry is really important. So not only what are the time points for your reassessments, are those going to line up with your required reporting? Maybe that's every 3 months, maybe it's every 6, but also the time frame for entering data. If someone misses that 6-month window, by 2 months, are you still going to collect that data, and how do you manage that? And then again, if you are going to use one of these other web-based platforms or have kind of any extensive evaluation, how are you going to fund and pay for the coordination of that project? Whether it's using mental health block grant funds directly as a non-billable service or including some writing within your case rate package or bundled care that specifies that you're going to use some funding for that. And that's all I have. I'm going to pass it on to Molly and Deborah. Thank you so much.
Hello, everyone. So we're going to kick off talking about providing more of a example of what we're doing in Texas to give you an example of what an evaluation could look like at the system level and also what we've collected at the site level. Next slide. So first, we're going to talk about why it's important to evaluate at the system level and not just at the individual level, specifically when it comes to first episode psychosis and other models like that that have been widely spread across the country. We're going to talk about how we are using the learning healthcare system, different options you have related to measuring fidelity to practice models. And then we're going to provide a little bit of data from Texas that we have been able to utilize from our state system and what our plans are moving forward related to collecting data at site level, and then also talking about the new initiative through the National Institute of Mental Health called the Early Psychosis Intervention Network, Epinepht, which is looking to do this work nationally. Next slide. So first, my question is to everyone is, have you ever been a part of a fidelity review process? So it doesn't just have to be first episode psychosis, just in general. Have you ever been a part of a fidelity review process? We'll give people just a couple more moments to vote. So it looks like it's about even. So of the people who voted that they are aware, about half said they've been a part of fidelity review before, and about half said they have not. So, next slide. As I'm sure all you guys are aware, there's always lots of conversations related to the disconnect between academic research and what happens on the front grounds. There's a lot of conversation about early psychosis related to a number of researchers who've actually looked at how much time it takes to for something that was developed in a university setting to get to the front lines. And the estimate says that it takes about 23 years for it to get to the front lines. Well, the reality is that with first episode psychosis, even though that work started over in Australia and the UK and elsewhere, within the United States, these studies that are related to what we're doing now in the US were initially funded in 2008. And the mental health block grant expansion happened around 2013, 2014. So it was much quicker than what you find usually. So at this point in time, we have hundreds of early psychosis programs across the United States. And Texas is one of, well, we're one of the largest states, but we also have one of the most teams across our state. We currently have 23 different teams across the state of Texas. But we still have a lot to learn. There's a number of different models across the United States that have their own version of coordinated specialty care. It looks similar. They're all more or less a multidisciplinary model, but they have different philosophies and are driven from different viewpoints. ISA tends to be a little more youth-driven versus On Track New York. And the RAISE programs tend to come more out of the traditional adult psychosis and schizophrenia researchers. So there's a limit of what you can learn from just an individual program. So while it's helpful to do internal quality improvement and evaluation, what can be most helpful is how we can get together as a group and learn over time. So that's what we're trying to do in Texas, is we have 23 sites. How can we work together to learn as a group about what implementation is looking like, what's working, what's not working. And since we're such a diverse state, where we have some of the largest urban areas and also some of the most rural and frontier areas, what things might we have to do a little different depending upon what the region looks like. But the pace can be really slow. It can take a lot of time to learn all these things. So the system is never as nimble as we want it to be. So we want to continue to have conversations about how we can improve things moving forward. And that's why we're using a learning healthcare system. Next slide. And the definition of a learning healthcare system is a learning healthcare system is one in which science, informatics, incentives, and culture are aligned for continuous improvement and innovation, with best practices seamlessly embed in the care processes, patients and families, active participants in all elements, and new knowledge captured as an integral byproduct of the care experience. Next slide. So the general idea of this is that we are trying to bring all those sort of things together. So it's not just about randomized control trials, and it's not just about thinking about the front lines and what people talk about, like practice knowledge. Is that we want to figure out how we can all work together and have ongoing conversations about what are the best practices, what's working, what's not working, and how might things need to be shifted, so that we can have a continual loop where you talk about practice to data, data to knowledge, and knowledge to practice. And those will can lead to change management and actions for change related to quality improvement and research. The other part of it that is very important is the idea of shared decision making. So it shouldn't just be people that have a PhD or an MD behind their name who are making decisions. It should be ongoing conversations with different people who bring different perspectives to the table, specifically individuals served and families, to talk about what their experience has been and what has worked well and what hasn't worked well. And also bringing people to the table who were served 10 years ago, who can talk about what their experience was and what would have been more helpful. So we can have an ongoing conversation to make sure that we are, as best as possible, meeting everyone's needs. Next slide. So this might be hard to see because there's a lot of words there, but the general idea is there's various pillars attached to the qualities of a learning healthcare system. So they're connected and aligned. So we have social, scientific, technological, policy, legal, and ethical. And that all comes together to lead up into the loop that we just, that I just talked about, which is the processes. So that's talking about change management and ongoing quality improvement. And then that moves up into what we're hoping to achieve through a learning healthcare system, is we want to talk about patient experience, population health, provider experience, healthcare costs. This is something that came out of traditional healthcare, so that's why I'm using the term patient. But the general idea is that it should include all the different elements. So we're not just talking about one specific thing, but we want to talk about individuals served, clinicians. We want to also look at from a population perspective and also think about value-based care. The one thing that can be very important when we're talking about first episode psychosis in relation to population health is that we are well aware there's well-documented research that says 75% of individuals who develop a serious mental illness that it happens before the age of 25. So we have a lot of epidemiological data that's telling us from a population perspective that there are things that we need to do to improve why we need to improve early intervention. So making sure that we're having ongoing conversations about that. That's why when Bess was talking about before about using information like duration of untreated psychosis, those sort of things can be tied back to a population health perspective to think about how we are improving that. It's not just in psychosis. The same situation happens related to major depression and bipolar disorder. There's a lot of research to show how long people go without getting adequate services. Next slide. So this seems like really big concepts. So where do we begin? The first thing, and what we try to do at Texas Institute for Excellence in Mental Health, is we like to start with collaboration. So we have conversations with providers, other researchers, individuals in care, their families, and funders. This is stuff that we're always having ongoing conversations with. We talk to Jessica and other people at HHSC. We talk to people at SAMHSA, NAMH, local private funders to have ongoing conversations about how we are best meeting everyone's needs. And then we have conversations about what can we do and what's doable. Just like they talked about in the first part of the presentation, we think through what data is available in systems related to electronic health records, the state systems, and how can we utilize those things, and then where are the gaps. So we try to always, our front line is always to think about what we already are collecting, but then only use things like REDCap or Qualtrics for things that there is no other way for us to collect those bits and pieces of information within the pre-existing system, because everyone already has enough things that they have to do related to paperwork and data collection that we never want to add on any more things. The other thing is that we want to have conversations about how can we have data available in real time to inform decision making. So if we collect it in a way that it becomes so difficult for us to be able to analyze and sift through over time, that's not the best way for us to accomplish our tasks. So we think about sometimes that means having conversations about reliability and validity and things that you maybe wouldn't do for a randomized control trial, but what things make the most sense in the real world for us to make sure that we get the best data we can within the situation. And then we talk through how we can make sure to have those ongoing conversations, what processes and structures should we have moving forward to incorporate knowledge moving forward, what structures should we build within the systems, and what sort of policies and fundings to best align with our best practice and promotes those values. So this is an ongoing conversation. There's been a lot of focus and interest within the state of Texas related to first episode psychosis. We have grown from originally 2 sites to 23, and those things happen because of these ongoing conversations. Now I'm going to hand it off to Molly.
Thank you, Debbie. And I just want to be real clear as we talk about this concept out of the healthcare system work, that this is a vision for us. We hope to be there someday, but we also are really just at the beginning part, right? So I want to acknowledge that we are excited to kind of move into this sort of a framework. And it's kind of what we're trying to think about as we build an evaluation system across the programs, but we're not there yet. One of the things to think about when you're thinking about having multiple programs is you need to understand what's similar between them and what's different between them. And you need to understand sort of what are they doing. And so one way to think about that as a starting point is around fidelity. So really kind of understanding a bit about the fidelity of the program qualities that are happening in your systems. And so here's some examples of different fidelity models, fidelity tools that are out there that go across different models or come from different traditions of coordinated specialty care. In Texas, we have been using the one that On Track New York has developed, but you might really look as well at the first episode psychosis fidelity scale by Addington, which is actually a model non-specific. So they actually have gathered information and consensus across a variety of programs to try and capture the core features of coordinated specialty care and identify those within a tool. So a lot of great tools out there. Another thing to think about if you're thinking about fidelity is also measuring fidelity to the specific interventions that may be happening within your coordinated specialty care program. So for example, there is a relatively new IPS, so supported employment model fidelity for young adults. It's kind of an adaptation of the adult model fidelity scale that might be of interest to folks to look at. You can look specifically at fidelity to IRT if you're using a Navigate model, fidelity to a CBT for psychosis, fidelity to the guidelines, etc. So not only fidelity at the broad program level, which is going to look at your team structure and what services and supports are offered, etc., but also at the specific evidence-based practices that may be within your program. This is an interesting sort of strategy that was used in a research study that really tried to gather some information from the young people, from the service participants, about their experience of different aspects of fidelity. So asking questions like, did your team make you feel that decisions about your treatment were shared between you and your team? And getting that information directly from individuals who are participating in the services and supports. Did you feel like it helped you get or keep a job or go or stay in school? So again, another way of gathering some fidelity information through a self-report type of format. So a little bit about Texas, just to give you a sense, as Debbie mentioned, there are 23 programs currently funded. Here's kind of a map demonstrating some of those. You can see by the color coding that the darkest ones were the very first programs that were opened in 2 very urban areas of the state. In 2017, there was significant growth across a number of other regions. And then in 2019, even greater growth, especially including a number of rural programs. The state uses the On-Track New York model and utilizes mental health block grant funding for these programs. They are housed within community-based mental health services programs. They serve youth age 15 to 30, and this is not consistent across all of the US, but in the Texas programs, they do include affective psychosis in addition to diagnoses of schizophrenia. And like I said, we are really just beginning the evaluation journey in our state. So really, we're just sharing with you some of our thoughts about how we want to be doing this work. We have had an opportunity to evaluate some of the some of the programs that have been in existence for a little bit longer. So just sharing a little bit of the data based on On-Track New York's fidelity scale. And that scale presents information in a percentage of elements that were met as either acceptable or exceptional. So acceptable is illustrated in the orange color and then exceptional in the darker gray. And so you can see that across the programs, the vast majority were meeting all of the different elements as being acceptable and of reasonable fidelity, and also had a fair number, but more variation here in the number of elements that were being met at an exceptional level. So going above and beyond what might be expected in the basics of the practice. And you can see across the fidelity scores there as well, more broken down into some of the different elements that were measured and then ranked. So the majority up until staffing, you can see were met at 100%. And then we were able to use some of that other data to look at areas where there may need to be more training or more problem solving around some of the barriers that sites have experienced. So for example, you'll notice that the nurse element was the lowest element in terms of meeting the criteria for acceptable, and that was a bit of a staffing issue, right? It was the challenge of finding adequate staffing in order to have that element of the team always in place. One of the other things we looked at that we had found interesting is we were doing some qualitative interviews and had wondered a bit about the differences that we were noticing in terms of some of the more experienced sites versus some of the newer sites. And some of the newer sites seem to indicate that the young people they were serving maybe having more challenges than some of the sites that have been in existence a little bit longer, and seem to be talking primarily about adults and young adults in their services. And so we wanted to just explore whether we were seeing any differences in the types of individuals that they were bringing into their coordinated specialty care. So this is looking a little bit at the age and the proportion of individuals in care who were adults, so 18 and older, or children. And so you'll notice our blue line is our oldest programs, and the gray line then is our programs that came in FY17, and the orange lines are our newest programs. And so what I take from this data is that we really did not see a difference across each of these different cohorts of programs. They were definitely seeing more adults than young people, but they all had very similar proportions of young people. I think the one exception could be our oldest programs, which actually were serving predominantly adults until the more recent last couple of years. Another thing we were interested in looking at was program retention. So we explored a little bit about this. If you were a part of Dr. Jones's presentation earlier, you heard that individuals leaving care is a significant problem nationally and internationally. And so one of the things we wanted to explore was the extent to which folks stayed in services. And our data really mirrors in some ways what Dr. Jones was presenting in terms of frequency of dropping out within the first year. And so this is a curve showing across all of the folks what it looks like over time. And so the people that are under the curve really represents the proportion that are still in services. So at day 0, basically your baseline when people enter services, obviously everybody's in services. And then as you move out further and further, get closer to that 365-day mark, we're looking at more about half of the people in care. So that tells us something, right? That's important information, but we might be able to find out even more information from that kind of data. So a couple of other things we looked at was to what degree different characteristics might impact our ability to maintain people in care and engage them in care over time. So these two graphs show information about gender on the left-hand side, and then also about race and ethnicity on the right-hand side. And so one of the things I want you to take from this, the color that's around those lines really shows you a bit about the standard error that might be in the analysis. And when they overlap, that means that there's not really significant differences. So when we look at the gender rating, you can see that after about 180 days, it does look a bit like individuals who report as male may drop out a little bit earlier, but that does not seem to be really statistically different. They're overlapping curves. When you look at race and ethnicity, again, you see a few differences in the curves, but in reality, many of our ranges are overlapping. And so we do see that individuals who identify as Hispanic are sort of at the top of the curve, so remaining engaged a bit longer, and individuals who identify as Black or African American are at the lower end, but again, a lot of overlap, so no clear differences that we see. One of the other things that we looked at, since our programs do include a number of folks with affective psychosis, was diagnosis. And here we do see some, I think, some interesting things that might bring up some questions for us. So if you look at these curves, the top 3 curves up here, which you'll see over here, include individuals who are diagnosed with schizophrenia or schizophreniform, schizoaffective disorder, and bipolar disorder. And for individuals who have received these diagnoses from clinicians, we don't see a lot of difference in the dropout from services. For individuals who are diagnosed with major depression, there does seem to be a more rapid disengagement from care and a greater disengagement from care within our data. And also for those who are identified with other psychosis, we also see a more rapid dropout of care, which might raise some questions for you about whether or not that might indicate that individuals may not have been appropriately diagnosed early. And as the program spends more time with them, has maybe determined in partnership with them that maybe this was not the right program for them. Or perhaps there are other explanations for this, but it at least starts the conversation that we can have with individuals to understand what may be impacting folks in terms of disengagement from care. So just another slide or two. We mentioned briefly this idea of Epinepht, and I believe that it also was introduced in the initial presentation as well. So what this is it's a concept. It was outlined in 2015 by the National Institute of Mental Health, and it's about creating hubs of early psychosis programs across the country that can use this model to continue to grow and develop and answer some of the really important questions, including those questions that have been highlighted in the presentations that we've had so far. It will create a way of gathering information about individuals in care that can be used across all of the systems to really get around some of those difficulties of small programs not being able to answer sometimes those really important questions because they may only be serving, 20, 25 people at a time. It's also around promoting measurement-based care. So how do we use these measures to really make decisions? How do we share them with the individuals that we are working with so that they can be empowered as well to use those measures? And then how do we continue to grow and learn and become innovative with the use of instruments and data? So real quickly, here are the existing sites that are funded. So you'll see California, the Espirito program is across 4 different states. Massachusetts, New York, and Minnesota are each a part of the current Epinepht sites. And just some of the research questions that they're proposing to look at. They're looking at developing a measure of duration of untreated psychosis so that there can be some consistency, looking at using apps, looking at examining ways for us to do treatment through electronic engagement, since we know that that's been something that we've been forced to do rather quickly with COVID, looking at ways of trying to reduce the risk of suicide for individuals in care, etc. So that was really quick, but I am going to wrap up and pass it back to Jessica.
Awesome. Thank you guys, everybody, Molly, Deborah, Bess, Annette, for your awesome presentation, your insight, and your expertise. We have several questions in the Q&A pod, so I will let my colleague April Rosas, MSSW, Residential Treatment Center or RTC Coordinator on the Children's Mental Health Unit from Texas HHSC, lead us through our Q&A today.
Hi, everyone. We are going to get to the first question. So the first question that came in is, I'm curious about what measures are used for social participation.
I can just say briefly that this is something we're really interested in and have started to look at. I don't actually have a specific answer, but we have looked at using social network connectivity as a possible way of examining, how early programs, our program is called Early, how CSC programs can increase social connectivity amongst participants. But yeah, it's a great question, and I think there needs to be a little bit more work in validating those types of scales.
I mean, I believe we've used some stuff from the recovery self-assessment, or we've had discussions about using some stuff like that for RSA. Some of the stuff that, and this also relates back to stuff with the Bess is talking about, the problem with a lot of these measures are they were created for like kids, like 11-year-olds or 40 or 50-year-olds. There are very few, if any, measures that are an excellent fit for young adults, which is what we regularly run into. A lot of people like to use the quality of life measure that's been around for a long time. And some of those questions just aren't relatable for your standard 18-year-old. They'll talk about like, do you have trouble walking upstairs or other things like that. So this is an ongoing conversation about trying to figure out, right now, I'd say we're using what exists out there that's validated, but is an ongoing conversation about how can you have more young adult friendly tools that aren't so focused on disability, because that's not what we're trying to focus on. We're trying to focus on work and school and other developmentally normative things.
And I'll add just a few. I was quickly trying to pull some of them up so I could see them more easily and not say them wrong. One of the things that's, I think, pretty commonly used is a global functioning for social and role functioning. It's completed by clinicians and looks a little bit like the old GAF kind of model. So that is commonly used because it's low burden and pretty quick to do. There are some really kind of interesting scales that get at more quality of life or recovery goals. We're looking at using the questionnaire about the process of recovery as a self-report tool. We've also been using the personal well-being index, which is more of a quality of life measure. And then another instrument that we've been using that I've really kind of enjoyed is called the mental health competence scale, that really gets at kind of a self-advocacy sense of kind of competence and ability to impact the services and supports that folks are receiving. I think that is kind of a nice one as well.